Hi, I'm Captain Peter McCarthy. Most of you know me as either a naturopath who talks about stress or as co-host of the Psychiatric video series, Wake Up America. However, today I'd like to talk to you in my capacity as a recently retired professional pilot. I spent over 36 years in military and commercial aviation, in the process logging over 17,000 flying hours in military and civilian high-performance jet aircraft. For the last 7 decades, the Federal Aviation Administration, or FAA, has been very aggressive about pilots not only not flying while consuming alcohol, but not taking any over-the-counter or prescription medications except aspirin and very mild nasal spray while flying. Unfortunately for all of us, that has now changed. In early April, the Wall Street Journal published an article on the FAA announcement that the agency was lifting a 70-year ban on pilots being able to fly while on antidepressant medication. Given the gravity of this decision, you would think that the FAA would trot out a distinguished panel of scientists whose extensive research supports the decision. Well, the opposite has happened. Leading experts have weighed in against the FAA's decision. None with more expertise than Dr. Peter Breggin, MD. A June 16th article on the Huffington Post, which is written by Dr. Breggin, who's a psychiatrist in private practice, lays the case out. Before the FAA's ban was lifted, Dr. Breggin appeared in court as an expert witness, testifying against a pilot who sued the FAA to allow use of antidepressants while continuing to fly. Dr. Breggin correctly points out that all of the medications allowed by the FAA carry the Food and Drug Administration's most stringent warning labels. These labels warn of side effects when taking these drugs such as aggression, hostility, mania, and other abnormal behaviors. Further, the medication guide that comes with these drugs includes warnings about additional side effects such as suicide and violence. Given these warnings, the title of Dr. Breggin's article says it all. The FAA is risking our lives with this decision. Speaking as a former pilot, I'm appalled that this 70-year rule is being swept aside. There are way too many situations during any normal airline flight, much less an emergency situation, where a pilot's judgment and decision-making skills need to be absolutely razor sharp. The fact is, we just don't know how an individual on one of these medications will respond under these circumstances. We can't know for sure if a pilot will respond positively to such medications or will experience a detrimental side effect, one which could be fatal to both them and the people flying with them.
Thank you all for attending today's hearing. I think it's an important one, and is to look at the potential relationship between psychiatric medications and suicides. I want to introduce the first panel. We have Dr. Peter Breggin, a psychiatrist and author from Ithaca, New York. Please enlighten us. You have the floor.
Well, I am Peter R. Breggin, MD. I'm a psychiatrist, and I was in this area of D.C. for most of my career, and then we moved to Ithaca, New York, to be in the country. In the early 1990s, I became the first psychiatrist to speak and write extensively about violence and suicide caused by the newer antidepressants, beginning with Prozac, later going on to Paxil, Zoloft, Celexa, and other drugs. I also, as a result of that early research, became the scientific expert for more than 100, I think it was like 170 cases that were combined by a court to provide the opportunity for one person to research the data and look into the company files for all of the suits, and I was chosen to be that one medical expert. This ended up giving me experience that literally no one else in the world has had in terms of looking at the basic data from Eli Lilly and then from some other drug companies. I was shocked at what I found inside the company. For example, the German equivalent of our FDA had become concerned that they were finding an increased suicide rate on studies of Prozac. So they asked Eli Lilly, and this is back now in the late 80s, to go back and look at all of their clinical trials and report to them on the rate of suicide attempts in the controlled clinical trials with the drug versus placebo. Lilly found, depending on how you counted, a 6 to 12 to 1 ratio of suicide attempts, not just thinking, attempts, in the control group compared to placebo. Lilly never made it public. They never gave this report that I found to the Germans. They never made it available to the FDA. I also found memos inside Lilly explaining guilt and shame on the part of some German investigators for Lilly that the company was classifying suicides and suicide attempts reported by doctors to them as no drug effect or other harmless kinds of entities, thereby disguising the suicide attempts and the completed suicides. And one of these memos, the gentleman declared, how am I going to explain this to my family? It was a genuine shame. At the same time, the FDA conducted a study comparing Prozac to an older antidepressant, trazodone, and factoring in the increased number of prescriptions for Lilly, for Prozac, and also factoring in the controversy, because the controversy hadn't broken out yet. There were far more reports of suicidality, violence, and other mental adverse effects on Prozac. I worked on these issues for many, many years, as you know, and then testified before the FDA in 2004 on a couple of occasions. And the agency distributed one of my papers written in 2003 to the panel, the FDA panel. And a lot of the language in the current label virtually reads like many, actually very, very similar to what I had to say in these, in my papers and books. Now, my conclusions in this testimony are based not only on these very early studies that I discovered inside of Eli Lilly, which, by the way, you can find on my website, the Lilly documents I'm describing, and I describe them in a couple of my books. But my conclusions are based in part on the many citations in the paper I wrote specifically for this committee. I actually sat down and wrote your paper. Antidepressant-induced suicide and violence, risks for military personnel, and in the hundreds of citations in my book. My recent book, which Mr. O was kind to mention, and which I know that you have read, Mr. Chairman, Medication Madness, gives an overview of my clinical experience, which now included in the book more than 50 cases of violence, suicide, and crime, most of them on antidepressants, and I actually interviewed survivors. I actually went to crime scenes, read all the medical records, police records, and clearly documented Medication Madness from a clinical viewpoint that there are many, many cases like this. I actually have over 100 that are mentioned in the book and 50 documented in detail. In 2004, after the various hearings, actually before them, required the antidepressant manufacturers to review their clinical trials. The FDA itself concluded that the newer antidepressants double the rate of suicidal thoughts and behaviors in children, youth, and young adults up to age 24, which of course is very menacing for the soldier population, the military population. Now, you get a doubling of rates. Well, what does this mean? Well, the clinical trials are very short. Most of them average about 6 weeks. Some of the Prozac trials were 4 weeks. Suicidal patients are excluded from clinical trials. The patient is monitored every week by experts and informed of all the dangers, presumably, and the patient is given huge hope. You're in this wonderful research setting where you're getting something new and wonderful. And furthermore, there's no attempt to look for suicide attempts and to categorize them. Now, when you get a doubling of suicide under those conditions, suicide attempts and ideation, under those conditions, you can assume that in the military or clinical practice it's going to be multiples, unknown multiples, because there it's given for months, there it's not monitored, there psychotic patients are included, there suicidal patients are included, and all of that's excluded from the clinical trials. Now, one of the questions that may come up today is that there were, in this particular batch of trials, no completed suicides. The shock is how many attempts there were, because the best way to treat suicide, if there were one, would be to simply put somebody in a clinical trial and give hope, because suicide is loss of hope. And that's why when you get all the doctors looking at you and testing you and working with you, you almost never get suicides in any kind of clinical trial of that kind. Now, the FDA warnings that came out of these hearings are identical for all antidepressants. The Zoloft label is the model I'm going to use, and it begins with a huge black box, very rare thing, with the title Suicidality and Antidepressant Drugs. And I'll read you just the first line of it. Antidepressants increase the risk compared to placebo of suicidal thinking and behavior, parentheses, suicidality, in children, adolescents, and young adults in short-term studies of major depressive disorder and other psychiatric disorders. And later in the label, they'll say that a lot of the adverse effects occur in non-psychiatric patients. This black box is very lengthy, and many of the items are repeated over and over again. It's the only label like that I know of. The black box is followed by a very ominous section, still in the warnings, entitled Clinical Worsening and Suicide. This idea of clinical worsening that's repeated in the label is not given enough attention. It states in this section that the following symptoms I'm going to list, quote, have been reported in children and adults taking antidepressants, both for psychiatric and non-psychiatric purposes. And the list includes anxiety, agitation, panic attacks, insomnia, irritability, hostility, aggressiveness, impulsivity, akathisia, which is psychomotor restlessness, and the DSM-4, our major document, points out that akathisia leads to violence and suicide. So I interrupted. Akathisia, hypomania, and mania. And mania is an out-of-control state that increases vastly the risk of violence and suicide. This is the list that's virtually taken from several of my earlier publications. And note the mention of irritability, hostility, aggressiveness, and impulsivity. Imagine causing that in young men and women who are heavily armed and under a great deal of stress. And irritability, hostility, aggressiveness, impulsivity not only lead to violence, but to suicide. Many suicides are out of anger and irritability and resentments.
Dr. Bregan, if I don't mean to interrupt, I just want to ask a specific question. If say, an active duty soldier is given these medications, they may not even see that warning, right? I mean,
well, my experience, last year I spoke at the oldest military stress conference given. Bart Billings, whom you know, a retired Army officer and psychologist, runs that. And I talked to generals and I talked to mental health professionals, and they all agreed that these warnings were hardly ever presented to the soldiers, and that the Army was, in a sense, acting as if it was unaware. And some of these people gave me estimates, not of the 15% on psychiatric drugs that we often hear, but up to 30% of soldiers in some sections, Marines in particular, was one that was mentioned to me.
So they're not even informed of the risks.
No, no. And as we go on further, we'll see that the FDA tells doctors you should, and the word should is in the label, you should share this information with the patient and the family and make sure they understand it. It's not just you repeat it to them. You sort of, you know, hey, I want you to understand, this is what may happen to you. That's what I do in my clinical practice. I don't say, by the way, the drug may cause this or that. You know, I just make sure over a period of many sessions that the person understands the risks. Now, did I answer the question, sir? In addition to this, this list that's associated with the drug itself, the antidepressants, and this is mentioned in the label and in the mentioned in the medication guide I'll tell you about, the antidepressants often cause severe withdrawal reactions in which all of those symptoms, all of those adverse reactions can develop. In fact, I spend probably half my practice, even in remote Ithaca, treating people who come to me to try to get off of these drugs and are suffering violent feelings, suicidal feelings. And in fact, in the last 3 weeks, I've had at least 3 or 4 patients who, as we went down lower on their doses, developed really, really frightening reactions, and then I had to treat those, usually by raising the dose back up for a while.